Hello and welcome back to the Mullen Institute webinar mini-series on emergency health workforce policies to address COVID-19. I'm Dr. Natalie Kurlishin, a practicing emergency physician and assistant professor of emergency medicine, health policy, and management at George Washington University. I have the pleasure of directing several policy education programs for physicians in training, including the Residency Fellowship in Health Policy here at the Fitzhugh Mullen Institute for Health Workforce Equity. Today, we'll be examining the issue of hazard pay for healthcare providers. Hazard pay, as defined by the U.S. Department of Labor, is additional pay for performing hazardous duty or work involving physical hardship. The provision of hazard pay has gained a lot of attention nationally as frontline providers, including my colleagues and I, struggle to balance professional responsibility against personal risk amidst the COVID-19 pandemic. To help us explore this timely issue objectively, we have three panelists: an economist to help us understand the big picture, and two experts representing low and high wage workers, respectively. I'm humbled to welcome them all. We'll hear from Dr. Michael Strain. He's the Director of Economic Policy Studies and the Arthur F. Burns Scholar in Political Economy at the American Enterprise Institute, where he oversees the Institute's work on economic policy, financial markets, international trade, finance, tax and budget policy, welfare economics, healthcare policy, and related areas. Dr. Strain's own research focuses on labor economics specifically, public finance, and social policy. He's a widely published author and frequent media consultant who's also testified before Congress. Before joining AEI, Dr. Strain worked at the Center for Economic Studies at the U.S. Census Bureau and in the Macroeconomics Research Group at the Federal Reserve Bank of New York. Representing low-wage workers, we have Dr. Sarah Nolan, Deputy Policy Director for Healthcare at the Service Employees International Union. There, she leads work on a range of healthcare issues, including Medicaid, health reform, hospital financing, and long-term care. She previously served as the Senior Researcher and Research Director for the Joint Committee on Healthcare Financing in the Massachusetts Legislature, where she wrote a substantial part of the landmark 2006 Massachusetts Health Reform Law and oversaw committee work on Medicaid and other health financing issues. She's also worked on state budget, tax, and health finance at the Massachusetts Budget and Policy Center and on federal tax policy at Pew Charitable Trust. Finally, representing high-wage workers, we have Ms. Laura Wooster, an Associate Executive Director of Public Affairs at the American College of Emergency Physicians. She has extensive federal legislative and regulatory experience. Prior to her role at ASAP, she served as Senior Vice President of Public Policy for the American Osteopathic Association, the Director of Federal Affairs for Premier, a healthcare improvement company, and as a lobbyist and senior policy consultant for the Blue Cross Blue Shield Association in Washington. I'm excited to speak with all of our panelists on this timely issue. I have some individual questions for each of you, but as we get started, I'd just like to make sure that you have the opportunity to tell us about the frontline healthcare workers that each of your organizations represents, and if among them there are particularly vulnerable or exposed subgroups facing COVID-19.
Thanks. So the Service Employees International Union, SEIU, represents 2 million workers, half of whom work in healthcare. And of the 1 million workers working in healthcare, we represent a fairly wide range of healthcare workers. So nurses, interns, and residents, and a range of frontline hospital workers who tend to be earning lower wages. And importantly, for this discussion, I think we also represent nursing home workers and home care providers, typically working in Medicaid programs that provide long-term services and supports in the home. But I do want to mention that we also represent 1 million public sector and airport building services workers who are also affected by COVID somewhat differently, but hazard pay is an issue for many of them because they are doing essential work and being asked to, show up and often in ways that risks their health. And I would also just mention that our members are affected in very different ways. Some of them are being furloughed, both in the healthcare sphere and the public sector and building services. And then others are on the front lines and particularly I would say nursing home workers and home care workers. So just focusing a little bit more on LTSS providers, so providers of long-term services and supports. We represent nursing home workers, mainly certified nursing assistants. And then we also represent home care workers. And to say a little bit about home care workers, sometimes called personal care attendants, because this is sort of a misunderstood population. So these are not home health workers that are, provided and funded under Medicare. They're typically working in Medicaid, or practically universally working in Medicaid HCBS programs. In both cases, nursing home workers are particularly on the front lines. We've heard about shortages. Roughly, I think, half the deaths that have occurred so far are in nursing homes. So there's kind of a nursing home set of issues. Home care is a little bit more complicated because what we are seeing is both home care workers potentially being exposed because they're often caring for people who are particularly at risk for COVID. But what we are also seeing is home care consumers being fearful of having a home care worker come to their home and often having another person to take care of them because that person has been laid off or is furloughed or is teleworking at home. And so saying to the home care worker, I don't need you now, I'm scared to let you into my home, please don't come in. And so what I would just kind of highlight here is that there is a whole complicated set of issues in terms of thinking about the effects on this particular set of workers. Next slide. And so I just want to note that when we're thinking about hazard pay, or what we've been calling pandemic pay, that there's a whole set of challenges that actually predated the pandemic that I think is really important to consider when thinking about the important role of hazard pay. And so one of them is, or a couple of them are the fact that this group of workers receives extremely low wages, typically lacks benefits such as healthcare, has historically themselves not only had their jobs funded by Medicaid, but relied on Medicaid and other public assistance programs. There's a historic lack of recognition and devaluation of this work, a notion that these people are just companions. And so historic exclusion from labor protections, such as overtime, until quite recently. A lack of training, a notion that you don't really need training to do this job. That's not true for CNAs, but it is true for home care workers. And then, and the result of all of this is high rates of turnover and workforce shortages in both nursing homes and in home care that really completely predated this pandemic. And frankly, I think the pandemic exposed the cracks in the system, but it didn't create them. I think it heightened the need to address them. So just to put some facts on to add to the previous slide, the current, as of 2018, which is our most recent data, nursing home, folks working in nursing homes, mainly CNAs, earn an average of $13.38 an hour. Home care workers, an average of $11.52. I would say in places where SEIU has organized workers, those numbers are higher, but not a whole lot higher. We've gotten to $15 an hour for workers in some states, but that's not a ton of money. You'll see that if you do the math, you can tell that nursing home workers not working full time. That is because many nursing homes are so fearful of having to pay overtime that they cap hours, the result being that workers cannot get enough time or enough hours to make ends meet. And so they work in multiple facilities. And we are hearing anecdotally that our nursing homes in Washington state, for instance, think that they can track some of the COVID outbreak from workers moving geographically from one nursing home to another because they're working in two facilities and potentially carrying infection with them. In the current pandemic, we're facing things that other healthcare workers, I think at all ranges of income and in all types of jobs are facing, which is a lack of testing, a lack of PPE, exclusion from the paid leave provisions that were in the recent legislation, and then potential other issues such as cuts in hours because of the issue that I mentioned of, consumers not wanting a worker, being fearful of having a worker come to their home. And then I would say, wearing my state budget hat, future Medicaid budget constraints, as Medicaid budgets are, come under the pressure that I think all state budgets are going to come under. One of the things that tends to get cut first is home and community-based services because they are mostly optional under Medicaid. So I would say that when we're thinking about pandemic pay, it's certainly important, but it has to, I think, be thought of in, and we can get into this in the discussion certainly, but there's a question in my mind about how we do pandemic pay, but also think about longer term structural solutions at the same time.
Well, thank you so much for providing your insight regarding SEIU, as well as vulnerable folks working in nursing homes and home care specifically. I'd like to hear from Laura a little bit about ACEP and what's happening on the hazard pay front with your organization.
American College of Emergency Physicians was founded in 1968, and emergency medicine actually didn't even become a specialty, a full recognized specialty, until about 10 years later in 1979. But currently, ACEP represents 40,000 emergency physician members across the country who take care of 150 million emergency patients a year. So a lot of the work we do is not just advocating for emergency physicians, but also their patients and improving quality of emergency medical services. In terms of who amongst our members might be more vulnerable as we consider the COVID-19 pandemic, certainly any of our members who are working in emergency departments in the so-called hotspots obviously are more vulnerable. We're in close touch with our emergency physicians in Washington State back in end of February, beginning March, when this was really first kind of bubbling up. And they obviously were the most vulnerable at the time. And then more recently in New York City, obviously was facing just a really high volume of cases, especially in places like Elmhurst Hospital in Queens, where because of a really dense population and just lack of ability to have social distancing, especially in living situations, there was just a huge number of cases that emergency physicians were seeing and being exposed to. But beyond the hotspots, once you're looking at kind of all emergency physicians, I would say our residents who are still in training, our physicians that are still training, are particularly vulnerable. And there's a few reasons for that. One of them is just the number of hours they work. They work up to 80 hours a week. And so that just increases the more hours you work, the more hours you're being exposed to patients who are COVID positive. And then another reason is because they do month-to-month rotations in different settings, they're going through different settings. They're having to adapt to maybe different PPE requirements from different facilities, and even different workflows or ways that these different facilities or units, if they're within one hospital, are addressing COVID patients or potential COVID patients. So, that's one thing we've been trying to pay attention to, is how are residents being impacted differently than sort of a practicing emergency physician who's been out in the field for a while. Overall, all emergency physicians obviously are being impacted, like I said. Volumes are down, which seems really counterintuitive to a lot of folks that we speak with. I think they kind of tend to think of the media coverage of overflowing emergency departments, with just having like all sorts of patients coming in with COVID symptoms and sitting in the waiting room. And actually what is the case in most places, unless you're really right in the middle of a hotspot, is that volumes are down 40, 50, even up to 70% in some areas. The patients that do come in are a lot sicker, but most of them are not there because of a COVID issue. And if they are there, they waited as long as possible in a lot of cases to come to the emergency department. So as a result of these volumes being down, a lot of emergency physician practices or even hospitals are having to furlough, or in some cases even let go, the emergency physicians that they employ. And just in terms of, trying to kind of keep the doors open and be able to stay afloat, they've had to make some difficult choices.
I guess the first thing that we're trying to understand and learn different perspectives on is what the ultimate goal of providing hazard pay really is. Is it solely to ensure an adequate supply of workers during a crisis, sort of temporize the attrition that we may see, or is it to provide specific acknowledgement and thanks to those who may be risking their lives and effectively taking on greater hazard in their professional lives?
I mean, I think it would really depend on how it was structured. So you could structure a hazard pay program that was conditional on hours worked, right? You could, offer nurses and doctors and whoever else that are in hazardous situations, basically a supplement. If you work 8 hours, then you get, $80. If you work 10 hours, then you get $100, something like that. And, that could be thought of as a way to encourage people to keep working, a way to discourage attrition, because the more you work, the larger the supplement. If you just want to say thank you, on behalf of society, then I think you could just say, here's a Christmas bonus from the government for everybody who worked in an emergency room, and you may not condition it on those sorts of things. So the first thing to figure out, I think, is what is the goal, and then the second thing would be to design the policy. The policies could look very different. I mean, if you were really worried about attrition, for example, you could offer people a hazard pay bonus at the end of the year and say, were you, or every 6 months or something, were you a physician or a nurse working with COVID-19 patients over the course of the past 6 months? If so, here's $5,000. If not, you don't get anything. That sort of thing as a way to keep people in. So it just really, I mean, a lot of people are talking about this, but I feel like there's not a lot of specificity around what it is exactly that people are attempting to accomplish. And depending on what you're attempting to accomplish, I think you'd want to structure the program differently. The healthcare sector is in a very weird spot right now. The income that accrues to hospitals just plummeted in the current quarter. And that's putting enormous financial pressure on the healthcare sector. And I think there were even job losses, if I remember right, in the month of April. So, I would want to look to see whether or not there's actually bizarrely downward pressure on the wages and salaries that healthcare workers are made, that is driven by this shutdown and by the cancellation of elective procedures and doctor's visits and all that sort of stuff. That could serve as the basis for a rationale for some sort of a federal earnings supplement, particularly during a pandemic. So those would be some of the things that I would want to look at when thinking about whether or not hazard pay made sense, or when thinking about what specific form of hazard pay would make the most sense. But I haven't seen a good analysis of that. And still can't really speak to how to prioritize those different goals.
What really defines an essential health worker? What criteria should policymakers use to determine which workers are eligible for hazard pay? I heard hours of exposure come up in the introduction discussion. Is there something else or another element that you think policymakers should have in the front of their minds when deciding who might be eligible for hazard compensation?
I think hours of exposure, and I think, you know, and obviously any increased likelihood of being exposed to COVID seems to me a reasonable criterion. Without trying to go off topic here too much, I think I do think it is sort of an important consideration that there's a connection between adequate PPE and ultimately testing and hazard pay, or as we're calling it, pandemic pay. And on the one hand, but it sort of forms the basis for a criterion. If you're not getting, for sure, if you're at risk of exposure and not getting adequate protection, you definitely should get hazard pay. I would also say getting hazard pay should not be a reason for not providing you with adequate PPE and so forth.
Thank you. So I'm hearing time of exposure, intensity of exposure, and then maybe access to adequate protection. Laura, apologies, I didn't mean to interrupt you. Please tell us your thoughts.
No, I was going to say similarly, certainly hours of exposure or hours of potential exposure, since we don't always know which patients are positive and may not know for weeks, if at all, depending on testing availability. But I think also the type of exposure, how prolonged it is, and maybe how controllable protection can be. Dr. Nolan mentioned PPE, and that's exactly, you know, whether there's enough PPE, even when there's enough PPE in a perfect world, and we had all the N95 masks and visors and gloves and gowns, each time, you know, you put on and take off the PPE, there's risk of exposure. So there's only so much that can be controlled. You have other healthcare workers who may be frontline, but for example, if it's a receptionist at the intake in a hospital, certainly there can be some distancing measures. There can be a plexiglass put up. So there's some exposure there, but it's certainly not to the extent that a patient care technician, a nurse, or emergency physician would be exposed to.
And I know that Laura has some slides prepared to sort of walk us through. I'd love to learn a little bit more about what's on the table at this moment in time and what the future looks like from a legislative standpoint.
Sure, thank you. So there's a number of different proposals out there, and I'm not going to get into details on all of them. Certainly there's private sector hazard pay or essential pay. There's different terminology for it, differentials, as Dr. Nolan mentioned. And you've heard of companies like Amazon and Walmart are temporarily increasing hourly pay. I know Kroger grocery store has a $2 an hour differential, but I believe that's ending the middle of this month. So the private sector is providing its own kind of incentives or differentials to some employees. In healthcare, actually, it's a much lower percentage. I found an article that talked about 46% of grocers and other retailers are offering hazard wages as compared to only 29% of health-related employers. And I think the volume issue and the financial difficulties that a lot of hospitals and other healthcare facilities are facing right now is probably one of the reasons for that, compared to certainly Amazon, Walmart, and grocery services are in increased demand right now, as we've all, I'm sure, experienced ourselves. So that's the private sector. And then there's state and local proposals that are going on. And I'm not going to get into details of those. I didn't find any state laws specifically that have been passed, but I saw a number of proposals that have been raised. For example, New York City was considering providing, they had a bill out that would have like an extra $30 a shift for grocery workers of up to 4 hours, or $60 for shifts of 8 hours. So that was that. But then congressionally, there are a number of proposals recently, and we can go to the next slide to start those up. The first is Representative Norma Torres. She actually circulated a Dear Colleague letter a few weeks ago calling for hazard pay to be included in the next COVID package that Congress is just starting its work on, nickname being COVID 4.0 is really what we're calling it, or CARES 2.0, depending on who's speaking. But she had called for a number of different things in there, protections to improve protections for workers against infection and even retaliation by their employers. Financial assistance to cover some of the additional needs that healthcare workers are facing and other frontline workers, and then just overall financial support to kind of compensate for some of the dangers that they're facing. It didn't get into specifics, but it just called for hazard pay essentially to be included. And then the next one that a lot of people heard about was introduced by a number of Senate Democrats. It was not actual legislation, it was just a proposal that they put out, and that was the HEROES Fund. That really what it would do is have a $13 per hour differential on top of the regular wages for all hours worked in essential industries by essential workers, and there are different definitions of that. This did include federal workers, by the way. And what it would do is it would cap out at $25,000 for those that earn under $200,000 a year, or it would cap out at $5,000 for those that earn over $200,000 a year. So again, $13 an hour. And up to $25,000 or $5,000, depending on who you are and based on all those hours worked. The employer would be the one who would apply to the fund, and then when the employer received the funding, they would then distribute it to the essential workers within their employee. And all of that would have to be documented and auditable, so to ensure that the money actually did go to the individual worker who was on the front lines of this. Another proposal was then introduced more recently by Senator Romney, and that was called Patriot Pay. It was a little bit more scaled down, and instead of lasting until the end of the year, which is what the HEROES Fund proposal would have been, this would just be for a 3-month period. I believe it would be March, April, May, and it would be up to $12 an hour. And it would max out at $5,700, and it would only be for essential workers who earn under $90,000. And it would be kind of sliding scale. That up to $12 an hour would be sliding scale. So if you earn less than $50,000 a year, you would get the full $12 an hour. But if you earned between $50,000 and $90,000 a year, you would earn less than those $12, kind of sliding scale incrementally down. Another big difference on this one is that it would, whereas the HEROES Fund would be funded entirely by the government and then distributed by the employer, the Romney proposal would only be funded, 2/3 of it would be funded by the government, and the last third would be funded by the employer themselves. And then it would leave it up to Congress and the Department of Labor to decide who's essential. And then we have the most recent, which is in HR 6880, which was just released yesterday, and that's the HEROES Act, not to be confused with the HEROES Fund that we just talked about. So it's starting to be an overused term that I think is going to confuse a lot of people. But this was the introduction of legislation last night by the House Democrats, and it included it wasn't called a hazard pay in there, it was called, I believe, a pandemic differential, but it was pretty similar to the Senate Democrats' HEROES Fund proposal, in that it would be $13 an hour and you could earn up to $10,000 if you earn less than $200,000 a year, or that goes down to capping out at $5,000 if you earn over $200,000. So pretty similar to the HEROES Fund, it just changed it lowered the overall amount that you could earn through that differential. ACEP had its own proposal that we had kind of brought forth and asked for in our recent advocacy day, which was virtual a couple of weeks ago. Under the ACEP proposal, it would be kind of similar to the HEROES Fund in that frontline healthcare workers, including emergency physicians, would be eligible up to $25,000. Speaking for the physician side of it, one difference we had was that we would have the individual emergency physician apply to the fund rather than their employer. And that's because emergency physicians work in such a variety of employment settings, and some of them even as independent contractors, essentially. So we wanted to make sure, and we've got residents as well, we wanted to make sure the money went directly to the emergency physicians, since the hazard pay is an acknowledgement of the hazards they themselves are facing. So we had it narrowed down so that they would apply using their national provider identifier. That was really just the one distinction.
Thanks so much. I think it's a lot of information to take in and process, particularly if you're someone who doesn't speak legalese and isn't working in that capacity, but strictly clinically. So we appreciate your ability to sort of candidly break it down for our audience. A couple other sort of thoughts. You've seen a couple of different proposals come forth from Congress. We've got sort of a Heroes Fund, a Heroes Act in the last couple of weeks. What are your thoughts about these proposed policies, particularly those that essentially say, hey, if you're earning under 200K, you could earn X amount, but if you're earning over 200K, you receive a lesser amount. What are your thoughts? Do you feel that any sort of consideration of exposure commensurate with risk should be taken into account here, as opposed to a, let's just say, two sizes fit all breakdown?
Yeah, I think, I mean, again, I think it just speaks to the muddled goals, so if the goal is to say, this is a once in a century pandemic, it's a once in a century public health emergency, and society needs a certain group of workers to put themselves and their families at significant risk. And if they don't do that, then we're going to have a really catastrophic public health outcome. Then I think demarcating the payment based on income, I understand why you would do it, but I think it really kind of works against that goal. If the goal instead is to encourage people not to leave the profession, then you'd probably want it to be ongoing, or at least you'd want it to be more forward-looking than, predicated on things, only on things a person has done. But if you are trying to stem attrition, then, perhaps it is reasonable to have an income threshold in there, because, it's very, it would be very difficult for an anesthesiologist who's, 52 years old to say, okay, well, enough with practicing medicine, I'm going to go do something else. It would be much easier for lower paid, less experienced workers in the healthcare setting to do that. And so you capture some of that, by having an income threshold. But then you would want, I think, more of a forward-looking component to it than some of these proposals seem to have. So it's just not super clear to me, specifically what problem these proposals are attempting to solve. And I think if they thought, if that were more clear, then I think it would be easier to figure out, what exactly the best structure for these programs would be.
Are there any decent precedents that you've seen work well for hazard pay in the past, either in a private space, on a state or local government sphere, or even, at the federal level prior to COVID-19?
No, my sense is that they're kind of a mixed bag, and oftentimes there's not a clear goal or need. The market will take care of a lot of this. The existence of what economists would refer to as compensating differentials are well documented. Workers who are in more dangerous settings receive a wage premium for that risk, and that's something that exists in many different occupations, and is something that I think is well known and well understood. What makes this situation, and that's true for medical professionals as well. What makes this situation, I think, somewhat different is that the risk profile changed dramatically and suddenly, wages and salaries would need more time to adjust to that. But I think how much more time, I think, is an open question. So a lot of the rationale hazard pay is actually taken care of by market forces. Um, uh, so, and I think that kind of, makes a lot of the efforts to do this well ineffective. But as I said, it's kind of a mixed bag.
It's really interesting that you point that out. We've had a couple other interviewees suggest that, hazard pay is really already priced into so many folks' wages. I think the interesting sort of tension here from an economic space is the downward pressure on salaries that you indicated earlier by way of hospital volumes and elective procedures being down substantially, sort of pitted against this immediate jump in risk. And I'm curious to know, I'm not an economist, how long do you think it would take for those two competing forces to reach an equilibrium?
I expect the demand to swing back pretty quickly, and I expect most of that lost income for hospitals to be made up. And then I think in terms of the change in the risk profile, I think that just depends on what happens. I mean, if we end up with a vaccine in the relatively near future, then the risk profile won't really have changed all that much. If over the longer term, if this ends up being a situation where it's much harder to come up with a vaccine, and we have to live with this for longer than people are currently expecting, then I would expect to see fewer people wanting to go into healthcare as a profession, and that should put upward pressure on the wages of people who do. In part just because it's riskier.
I know that we sort of spoke a little bit about what constitutes a fair amount of hazard pay, and I would like to explore at this moment, asking Sarah specifically what some of the limits or potential unintended consequences of a short-term policy like hazard pay are, particularly for low-wage workers.
So I think, so one challenge is, and again, this goes back to the purpose of hazard pay. So if the challenge, if the issue is to address workforce shortage in the short term, fine, hazard pay works. Certainly doubling the essential, which is as based on the wage data that I showed you earlier, the proposed level in the HEROES Act would double the hourly wage for home care workers. However, it doesn't address, as I think we already touched on, it doesn't address the need for PPE. It doesn't address exclusion from any paid leave provisions for people who typically don't even have health coverage already. And it doesn't address the longer term workforce shortage issue. So my great fear is we do hazard pay, we bring in maybe some new workers, and then the emergency ends, the hazard pay ends, and somebody goes from earning $26 an hour to $13 an hour. And we're back kind of where we started. And so that goes, I think, to the need to broadly, and not just on this particular issue, to think about how, to think about the structural issues in our health system writ large that pre-existed the pandemic, and how we can use this moment to address them, or maybe not use this moment to address them, but how we think about addressing them in the future. And so there are a whole range of issues. It's hazard pay. It's the fact that CMS has waived training requirements for nursing home workers. And so, we assume the pandemic will be with us for some time, but at some point the emergency period as defined by the government will end. And at that point, things like pandemic pay or hazard pay end, relaxed training requirements end. And so what does our long-term services and supports system look like at that point? And one thing I would just, a final note is just to highlight that there's a need not only for hazard pay, but in the home care space where people are turning up in a consumer is saying, I don't want you to come in my home, I'm scared, there is a need for retention pay for those workers so that we have a functioning, so that we have a workforce so that we in place when those workers or when those consumers, you know, are no longer fearful and do need somebody to come back into their home. And so there have been a number of states have sought waivers for their home and community-based Medicaid programs that include retention pay, and CMS has been granting those.
So I'm hearing retention pay as a potentially more sustainable alternative to hazard pay, or a longer-winded policy change that might come about as a result of this crisis.
No, I mean, I think Dr. Nolan really covered it well, and I think that there's just an important point of what happens after, as she raised, but also when should after be? You know, I think it's going to be maybe a year before we see a vaccine, at least, hopefully, that's it. And so how long should people be earning hazard pay? I mean, one could argue that until there's a vaccine and or at least sufficient PPE and testing, there should be hazard pay, of course, but will that actually be the case remains to be seen. So I think that's just an added kind of factor and difficulty with all of this that policymakers will definitely need to try and address.
That's a really good point. So duration of sort of short-term relief is another point of conflict, it sounds like. I have one other sort of thought. I'm curious to know if you think that there's a better or more sustainable alternative to hazard pay. You mentioned a little bit earlier some really interesting ideas, if avoiding attrition and being able to maintain a cohort of critical workers is the goal, that perhaps spacing out payments to the end of a time frame where you think we'd need those folks on board could be one strategy. We've also heard from others, you know, retention pay might be another strategy.
Mm-hmm.
I know that you are very much an expert on tax policy as well. I'm curious to see if you think a different lever altogether might achieve some of the proposed goals of hazard pay.
Well, you could do a lot of that through the tax system. I mean, I think if you know, but yes, I mean, if the goal is to stop people from leaving, then you know, I think some sort of a, you know, more forward-looking, you know, okay, if you stick around for 6 more months in this occupation, we'll give you a payment that you otherwise wouldn't be eligible for. You know, and then I think a lot of it just depends on the circumstances. I mean, you know, if people are unable to get jobs or are seeing their hours cut as a consequence of the shutdown in the healthcare sector, I think certainly that needs to be dealt with, but I don't know that that needs to be dealt with in a way that's different than how we're dealing with it all throughout the economy. So better programs in general to support people whose hours are being cut, not to zero, but whose hours are being cut from what they normally would be, I think would be very important to have at a time like this. And there are some ways to do that. And about I think 27 states plus DC have programs on the books that allow workers to get prorated unemployment benefits when their hours are cut. So the way unemployment benefits typically work is you have to be laid off and then you get a benefit. But what if instead you didn't get laid off, but you had your hours cut by 30%? Well, then could you get 30% of a standard unemployment benefit as a way to make up some of that lost income? Those programs exist in 27 states plus DC. They need to exist in all 50, and they don't yet. And they need to be more used in the 27 states where they're not used. You know, and so that certainly would help address some of the problems that the healthcare system and healthcare workers are facing, but it would also address, you know, the challenges that exist in other industries as well. So there's a lot out there that can be done right now. We just need to just need to do it.
I've got one other final question for you. I'd love to know how you think, if the goal of hazard pay would be essentially to provide compensation commensurate with increased risk, how do you really measure risk beyond hours? How do you delineate in a way that's actually doable the intensity of the experience that someone is undertaking?
Sounds very clinical, but a kind of standard way to do that would be to look at mortality rates of those workers, and so you can figure out you can statistically attempt to figure out what the risk of mortality is from being in a particular occupation. And there are a variety of statistical techniques to do that, but the basic thrust is that you're trying to see whether the probability of passing away is greater for people in a certain occupation than not. Trying to hold constant a whole bunch of factors that might otherwise influence mortality. And so that could be one way to do it. I mean, that doesn't capture illness. You could do the same thing with illness, of course. That would require data on who's getting sick, and it's harder to come up with that kind of data. But that would be kind of the first intuition of an economist would be to try and measure it.
Presumably morbidity could factor therein as well, right? If you've got other indicators of illness, or let's just say burden, economic or otherwise, even just in terms of clinical burden, I think that could be an interesting way to sort of stratify this as well. Of course, so many compounding variables, so many other factors would come into play, and try and, I think, differentiate how one was impacted by COVID. We don't even know at this point, if transmission that's happened has occurred on the job or otherwise for most individuals. So certainly a really tricky space, and understandably why policies that have been proposed to date haven't necessarily included any real, I think, assessment of risk accordingly. This has been a remarkable discussion. I really would like to sincerely thank all of our thoughtful participants for their time and their expertise. We on the front lines are grateful to have folks like yourselves advocating on our behalf and for considering all of the complex issues embedded in this particular topic. Thank you for all that you do.